So welcome, welcome. Can I get a raise of hands? How many people are not vascular access specialists? All right, that's awesome. This is gonna be fun. All right, yeah, welcome. Let's give it up for them for showing up. Yeah. I mean, the whole Association for Vascular Access started out without vascular access specialists. So everyone's welcome. It's applicable to anybody and everybody. Here are my disclosures. I am the board of member of IntraCath, director of clinical success at VenoCare, and these other consulting contracts that I have. I do have my biases. So with the information that I am sharing today, please double check them yourselves. Please vet the information yourself before you apply it to your own practice. So let's move on. Objectives, all these we're gonna go over. I'm gonna brain dump as much as I can. So if you're like, hey, I actually want you to answer a question, raise your hand, I'll get to you, okay? Interrupt me. This is your time, not mine. All right, so here are my 3 points of where we fail our catheters: dressing complications, flushing complications, and blood draw complications. These are where most of our reasons why we need to take them out happen under these 3 categories. So consequences of poor care maintenance, premature dislodgement. How much of us hate when the patients accidentally, or we accidentally, whoo, that one's more painful. Infection, obstruction, and waste. Okay, these are all the complications that happen due to issues with our IV catheters. And they're all kind of intertwined, and we'll go into that. And you'll see that during the presentation, how one thing also involves the other. So let's start with dressing complications. Here are the problems that we can produce with, anybody know what MARSI, does not know what MARSI is? Yes, I love it. I'm actually going to be useful today. I'm so used to talking to specialists who know more than me, so it's nice that I'm actually going to be teaching you something. Oh God, can someone please give it? There we go. Skin injuries due to medical devices, usually the adhesive. How many of you have taken off that dressing and there's blood and petechiae and the skin rips a little bit? Right? That's what this is. Pressure, bruising, ulceration from the catheter sitting on that skin, hypersensitivity, catheter pistoning, disruption of the dressing, and infection. Now, a lot of these issues are subsected to people with chronic illness diseases. Anybody know the term dysautonomia? Yeah. Okay. Ehlers-Danlos, HEDS, MCAS, I think MECFS is starting to get into that category. These are especially vulnerable populations, and for the specialists, I'm going to show you something unique that worked for me in those patients. Dressing solutions. So I don't like to just, actually I do sometimes like to just complain. However, today I'm hoping to give you guys some solutions as well. Adhesive removal solvents, they have been a huge game changer for my skin-sensitive, weak skin patients. Alternative to dressing devices, not just one. I have to be careful about brand, don't I? Yeah, so we'll hold off on that. So dressing lift technique, this special technique I use for my connective tissue disorder. Anybody know or came across connective tissue disorder patients and their unique complications with vascular access? Allergy testing is highly recommended, I believe, for chronic illness who are gonna have these devices for a very long time. CHG impregnated, dressing adhesive, alternative securement. Let's talk about MARSI first. These are not images from a 1970 textbook. This is from my patient about 3 years ago. It's still happening. And it's mostly because we don't know options for our patients. I talk to my DON and say, hey, look, this is what's happening. What can we do? Oh, the only thing I know of is silicone tape. So will the pharmacy provide it? Not really. And so we had to find alternatives for this patient. And so luckily, I got connected in the Association for Vascular Access, my colleagues, my mentors, and they were able to guide me towards different product solutions for the patients. Okay, so remember, these are for our vulnerable patients. Adhesive removal solvents. Do I mean this? This is fantastic. But no, not this one. It's not going to work well for this. It might make it worse. Do I mean this? How many of us use alcohol pads to get rid of that dressing when it's stubborn? Yeah, it can work if they're decently healthy, but not if they have this. The rubbing alcohol will make things worse. I learned that the hard way. So non-IPA solvents will help to dislodge that dressing intentionally with least damage to the skin. I did not know this existed until about 2 years ago.
About the any pain there?
Until then, I was using rubbing alcohol. Okay.
Is this moving around hurting at all?
No.
Good.
So I was able to get under that dressing and release it with minimal damage to the skin. There are things out there that we've developed, that these fantastic companies have developed for us. Pressure bruising. How many of you seen bruising from where the catheter hub lies? Yeah. And this is more for a long term. ED, I didn't really see this, but I did see this in my vascular access specialty profession. That's 7 days. That's it. Connective tissue disorder.
What's going to happen because this part of the catheter has harder plastic and it's going to cause tissue damage like that over time. She has exceptionally slower healing process because of her disease process. For other people, this could be an issue, not as dramatic, but skin breakdown. So this is why you don't want to hub the catheter because you're going to cause something.
You could even see the outline where the catheter hub was resting. So she started to develop blood blisters and skin breakdown, ulceration within 7 days. This is a 27-year-old, so she's not that old. Yes?
What is the orange piece?
That's a, what's the CE? It's the sutureless subcutaneous securement device. There we go. I'm trying to make sure you guys get your credits.
Isn't that redundant?
Say that again?
Isn't that redundant?
Redundant for what?
Securing.
Well, you don't have the piece under the 2 holes now because you've got...
Oh, you're talking about with the other regular securement devices?
2 securements on that.
No, there's
I only see one.
one. That's the orange.
There's the option for this stop lock.
Oh, well,
So you can add it, but I didn't use it for her. Yeah, I only had this on her. Yeah, you don't, the second one's exactly, it's redundant, you don't need both. You only need one. In fact, I've got some pictures where both actually complicated things. So you really just want one or the other for this one. And so I used a gauze to distribute that pressure more evenly, and that helped with the blister. So here's an option for those patients who have this connective tissue disorder. So this is my lift technique.
And preventing it from slamming down is helping to preserve the feet to be in the skin, under the skin subdermally and not be pulled up by the tension of the fulcrum from slamming down to the skin. That's something to consider with these connective tissue.
How many people have been changing dressings and using this particular securement device for over 5 years? Okay. How many have you seen the feet come in and through the skin over time? It's a specific problem for connective tissue disorder patients. I didn't believe it when the internet told me this happens. I was like, I put hundreds of these in patients, get out of here. And then my one patient had it. I was like, what the heck is going on? It's a very small subset of patients with connective tissue disorder where their skin does not hold well together, and so they easily ulcerate no matter what. So why did I continue to use this device when that was a complication? Allergies to acrylic, allergies to cyanoacrylate, allergies to polyurethane. I found out much later. I know that's a polyurethane catheter, but she was actually reacting to that catheter as well. So I did not have, and I'm definitely not going to suture, right? So there's lots of complications with other devices that I could not use. This was the only one that she did not react with her immune system. And so I had to try to keep that in there, try to secure it. And so this was a solution, and this worked really well in keeping that catheter secured with that particular device. So this is just my technique I wanted to share with everyone that helps to keep the longevity of that securement device as well.
So that on there, you're going to continue to get that leverage, and then we'll use this to rest our hub, like so. So we're going to tape it like this. I don't want it to end at the flexion of her elbow. So I'll do it like that so it's out of the way for her. And the hub itself won't put too much pressure on her skin.
So if you could think of a fulcrum, a seesaw, if this is my skin and this is the device, if I slam it down, there's all this back pressure from underneath. And so I try to keep it up to prevent that pressure from inside out. So this is another option that you can provide. This did really well. It's not perfect, but it helps to keep it from ulcerating.
So I'm pinching at the line of the back line of the package to match this in parallel here, and then I pinch it.
And then I,
What kind of dressing is that you're using? You don't have to give me a name brand, but what, that's clearly not an outside type of technique.
this was a lesser concentrated acrylic dressing. Yeah. So there's only one brand that I know that exists that manufactures central line dressings with silicone adhesive. This was not that because we didn't, the pharmacy refused to provide the patient with the silicone dressing. So we had, I don't think so. Oh, you mean the powder?
Well, anything, do you have anything in the back?
I couldn't because she was allergic to CHG.
So you're changing dressing every 48 hours or every?
No, every 7 days. We're using iodine to wipe. She for some reason wasn't allergic to iodine. Right. And so that worked out well for her, but other than that, no continuing antimicrobial device. The gauze are sterile.
But you have to change it every 48 hours.
Every 7 days.
It's still got the insertion site visible, I think is what makes it not the 48-hour gauze. It's when it's occluded by the gauze.
When you can't see if there's something wrong with it. Yeah. Yep. So again, please adhere to your policies. This is a very unique case. I don't expect you guys to do this every year. Maybe once every 3 years, hopefully. But this is just an alternative, at least in the back of your head, you know there's a way to keep this thing in the patient. So moving on to hypersensitivities. My patients who come to me who have these dysautonomia disorders, I have them, or chronic illness, I let them know, hey, I recommend you get an allergy test for these products. Because these are the common products that we're gonna use on you, and you're gonna have it for 7 days, 14 days, 2 years. And by the way, for you guys furiously writing notes, I will have a QR code at the end, so you guys will be able to download the whole PowerPoint. So if you want to just steal it, use it for your own institution, and change up whatever you want to change, you'll have access to that.
And we will upload it to the handouts later as well.
Yes.
On the handout link later.
So you guys will have access to this whole PowerPoint, and you can change it however you like. So one of the biggest things without the actual allergies or exacerbating the allergies is wet. How many of you were told, let it dry before you apply it? How many of you hate letting it dry and waiting for it to dry? Let's say waiting, right? That waiting period is so painful, but it's so important because if it's continually wet, the chemicals generally, most of them were not designed to stay wet on the skin. They don't test for that. So when it's wet on the skin for 48 hours, for 3 hours, the patient starts to have a reaction because of things that are happening while it's still wet. So making it dry, letting it dry is going to be key for the patient not to have react. Even if they don't have allergies, they'll still react because the body's like, what the heck is this? I'm not used to this. So chemical burns for antiseptic, that's also another fun issue. Let it dry or else you're gonna have these issues. Officially getting allergy tested, I recommend that, especially for chronic illness patients. Now, alternative dressings, these are some solutions that you guys can bring to the table and look for as well. I don't know what all products are. I know a lot of products, but I don't know what's all out there. And you guys might find something that I don't know. And so I want you to have in the back of your head, there's something to look for. Let's go find it. Let's see what's out there for our patients. So, catheter pistoning is another big issue. How many of us ignore this? You guys see that dot?
After preparing,
how many times did that dot go back in the skin?
Fix the CVC with a sutureless securement device.
It happened 4 times before I mentioned it, but only when I mentioned it did you guys start to react to realize what it was. How many times did I ignore the catheter pistoning in and out just a little bit while I'm changing the dressing? Not 5 centimeters, but maybe a whole centimeter, 2, right? We're like, well, this is how it's supposed to be. This is how, what can I do about this? It's an issue. So hopefully the manufacturers will listen and figure out and give us more solutions. Just know that that pistoning is introducing bacteria every time it goes in. Every time it's free, every time it's not anchored, not secured, it's going in. And so minimizing it as best as possible, eliminating will be fantastic. Okay? So, well, why don't you suture it? It'll never come out. Yeah, I don't know. Okay? Of course, we tried suturing. Here's a problem with suturing. I want you to watch the juxtaposition of the music and what's actually happening.
The skin protectant pad. Fix the CVC.
How many of you have changed dressings for a suture, like well sutured? That thing's not, patient can pull on it, that bad boy's not coming out, right? How well can you clean underneath? I mean, you could, you just pull the catheter out a little bit, get to it, and then push it back in, right? So how much pistoning is happening? No way is it pistoning. I sutured that thing so tight, patient's gonna ulcerate. You move the skin. The catheter might not be moving in and out, but I'm definitely moving the skin, right? So keep that in mind when you're doing your dressing changes with these sutures. The reason why the people putting these in and suturing them do not believe or understand this pistoning issues because they don't change the dressings, right? In a perfect world, CVC insertions, because I do them too, I get it. We want to be in and out. If that dressing doesn't stay on and stay intact for 7 days, the person who put it in needs to go change that dressing every single time, right? That'll teach these inserters, oh, maybe we need to rethink this because I don't want to keep coming back. Let's find a solution. This is a problem. So, now how do I change that culture? That's a Jack LaDunn problem there. So dressing disruption is the problem. The reason why is we're not letting it dry. The adhesion of the dressings are not staying on very well. Too much or too little skin barrier. I didn't know that till 2 years ago. I was like, what is too little? What is too much? Anatomical range of motion and catheter range of motion. Okay, so those are the things that are cause of pistoning. We need to do what we can to prevent that. All right, so we don't like this. It's, I love Jack's quote, do I need a study to prove to you that this is a risk for infection? Some of us, we do need a study. We want to see, oh, what about this one? There's no way, I sutured it. It's not coming out. Yeah, it's not the issue here. So what should it look like? It should look like this. And it's possible. These are insertions that I've done. You can point it down. Now, how many of you insert CVCs here? Yes. So we know we can do something about it. So how do you convince those in your institutions, hey, there's an option? I don't know the answer to that just yet. Maybe if you stick around, you'll hear Jack's talk and get some ideas off of that. Zone insertion method. How many of you heard of zone insertion method? Okay. Zone insertion method is, let's put it in a spot. I'm dumbing it down. Sorry, Rob Dawson, like for not, making it as pedantic as you've made it or specific. You want the insertion site to be away from flexion. If the dressing's on here, what's going to happen to my dressing? It's going to come off. It's going to pull off. What about here, right? What about here? Okay. So these points of flexions we want to avoid. That's the whole point of this, this systematic approach to insertion. So middle of the arm, if possible, it's not, you can't be dogmatic about it because sometimes the best place to insert it might be here or here. And there's other techniques that we have for that. If you're not a specialist, I'm not going to go too deep into it. However, just know that there are options, and know when you're doing these ultrasound IVs in the ER and the ICU, there is a method to preventing that dressing from coming out, okay? So, dressing disruptions, let the skin dry. Do you hear a repeated pattern here? Letting it dry. If anything, just let it dry. Like, just wait for it, okay? Thin layer skin protectant, dressing adhesion, adhesive devices, or dressing, not necessarily, you can use glue, but not necessarily glue. There's like gum mastic, adhesive, assistive chemicals out there. No protectant for silicone. Anybody use silicone dressings for central lines or PIVs? Oh. Well, if you ever come across it, don't use a skin protectant. It'll actually dislodge it a little bit more easily. So it's perfect the way it is. It doesn't need assistance. Insert it right the first time. That's the key. Even for the nurses who are inserting with ultrasound, we have to put it in the right the first time. All right. So infection complications. This is my favorite. All right. I may make some people mad with this statement, but just know I'm being hyperbolic, kind of. I don't care about your hand washing. I don't care about your scrubbing the hub. Because no matter how many, I can scrub that for 2 hours. But if I stop scrubbing and I contaminate it, that 2 hours was worthless. Right? There's moments and gaps in time where we can recontaminate that site. I can put on 7 layers of sterile gloves. And if I manipulate it and contaminate that site, it doesn't matter how sterile my gloves are. So where am I going with this? How many of us love that we stopped requiring masks after COVID? I loved it. And then I saw this video like 6 months ago and I was like, oh. You guys see what's going on? Yeah, it's gross. And when we're hanging out for lunch and you know, hanging out with each other, this is what's happening. So if it's projecting that far and all they're doing is talking and breathing even, depends on how hard you breathe, I guess, right? I'm right here. Is that droplet particulates going to get and reach this side? What about? Right? What about when we're inserting these PIVs? Oh, we clean the site. Hey, how you doing, Bob? You're in there trying to get that blind stick, trying to, you know. So wearing a mask is key. I don't have a study for this. All I know is that there is increased colonization. I think an anesthesiology group did a study to show increased colonization with mask or no mask. But that's all we have. Again, do I need a study to prove it? I think I do. But in the meantime, while we wait for data, I'm probably going to wear a mask while we're manipulating these patients' catheters. How many patients were never taught, or you were taught, you don't need to wear a mask when you're just flushing. Only wear it for dressing changes for report. That's it. How many of us taught our patients that? So I think we need to change the narrative of wearing a mask around these sterile invasions of the patient's body. All right. Yeah, that's a fun one. Okay, advanced flushing. Woo, this is going to be fun. Flushing complications, high pressure. Does anybody know how much pressure you're normally flushing at? The answer should be no, because none of us measured this. We're going to be able to measure it during the hands-on workshop. After this portion, we're going to be out there. 10:30 or 10? 10:30. Okay, perfect. All right, so
Breakout sessions.
I love it. I love it. I forgot about the 30-minute break. All right, so Pulsative versus Laminar. Does anybody prefer one or the other? How many people prefer Pulsative flushing? How many people prefer laminar flushing? Laminar is just one smooth flush. Yeah, okay, different use cases. Catheter, okay, let's talk. Catheter extravasation, blood reflux are also complications from flushing, and we need to be mindful. But I flushed for 20 years. What are you talking about? It's as simple as walking. Is it? We're going to figure that out today. So here's my solution. Low pressure laminar for PIVs, pulsatile flushing for CVCs, adequate vein purchase for that catheter pistoning, extravasation, correct clamping sequence. Correct clamping sequence. We're going to show you. And you're going to be able to play around with that at the workshop as well. So high pressure, what is this? Why do I care? Endothelial injury, we know this is the cause of thrombosis. But what is it injuring? It's this. I didn't find this out until about 3 years ago. My first AVA conference. I was like, what is Glycocalyx protein? Andrew Ballmer was like, hey, this is cool thing called Glycocalyx protein. I was like, huh. I want you to pay attention to this part. Its building blocks are protein and sugars. This is the root of everything we understand about vessel health, cardiovascular diseases. Okay, so this is the official definition. These are the functions. Again, you'll have this at your disposal. It basically protects the veins from inflammation and unnecessary inflammation and unnecessary clotting. It stops that cascade from the beginning, okay? Here are the diseases. Here's one I want you to pay attention to right here. With diabetes, what does insulin do? It takes sugar. So what are the building blocks of glycocalyx protein? Sugar. So if we have too much insulin throughout our life, what's happening to our vessel health? Why are diabetics have more cardiovascular diseases? Why is that correlated? This is the root issue. Okay, now, why does this apply to us? If you hear of a patient with diabetes, with atherosclerosis, sepsis, and inflammation, just know that their likelihood of thrombosis is going to be higher. So plan better for these patients. All right.
Your PIVs are clotting because the endothelium is being damaged by how hard you're flushing it. And as you can see,
I've definitely gotten in trouble for this.
That cement gets degraded and damaged. Same thing is happening with the endothelial lining. What happens when you damage the endothelial lining of your vessels? You start to develop clots.
What do you think is happening? What am I doing here? Am I drawing blood or am I flushing?
So then what happens when you clot?
I'm flushing.
Or you can't.
When I was in the ED,
One more tips and tricks, don't forget to plus that.
yeah, so when I was in the ED, I was told, yeah, flush it hard so you want to get rid of the clots, right? Oh boy, was I wrong. It's called the Venturi effect. So we're creating a low pressure environment by pushing the blood out of the way and the veins actually collapse. If the veins expand, there's a big problem. That means there's a full or enough of an occlusion that it's going to increase the pressure. Okay, so that's not a good thing. But at baseline, normally, the veins will collapse, start slapping each other, and that increases that mechanical shear force against that vein. So, how many in the ED or worked in the ED before? 5 years in Baltimore, okay, so I've seen my fair share of craziness. Not every patient needs adenosine. We don't need to slam every single flush for these patients. So we have to be mindful, especially if we don't want to have to replace these IVs. That's kind of what I'm getting to. The less we damage these veins while we're using it, the less likely we have to spend time reinserting, re-traumatizing, and taking up their vein space. So shear force due to pressures, angle of attack also makes a difference. And we're gonna talk about that. Friction from catheter pistoning. So this is an interesting study. It has a lot of holes in it, but a lot of the authors have followed up on this study. They found that the angle of rest of that catheter on the vein is going to increase the shear force. It makes sense. The more you point at something, the more likely it's gonna hit harder, right? And so this is something that we need to be mindful of. When we insert with ultrasound, with that deep vein, how is that catheter resting? In my anecdotal experience, when I've assessed and I was like, I gotta keep it in, I'm not gonna poke this patient again. It's just hydration or blah, 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 blah. It doesn't end very long. It doesn't last very long. But we get the treatment that we needed and called it a day. Extravasation, inadequate vein purchase. Shout it out, how long are your catheters? Anybody know? Your PIV catheters? Okay, 1.75. Do you know you're in the ED, how long the catheters are? I had no clue. I didn't even know there were other manufacturers when I was working in the ED, right? And so we had this
1.16.
1.16, that's fantastic. So, how much vein purchase is key? 232. Yes. I have mixed feelings about that, but I won't go there. So, adequate vein purchase, regardless of what measurement it is, you need enough in there. Why? Because it's going to come out. How is it going to come out? But how is it pistoning? Yeah, flushing.
While it's still anchored to the skin.
I'm not moving the catheter in and out of the skin, by the way.
This is pulling the skin.
I'm taking that skin and pulling on the skin. And it's moving about 1.52 centimeters.
This is
I could have stapled this, glued it, and melted it, smelted it onto the skin, and it wasn't moving the catheter. That's how much the patient's skin is moving. Okay, so if that's the case,
most CT protocols to deliver the desired image quality.
This is an interesting concept.
Is an undesirable complication.
Anybody work in the fire department at all before healthcare? There's a thing called nozzle reaction. This is what it is.
Vessel, unhealthy vein condition, or even the impact of contrast on the vessel at high flow rates.
Okay, so what's happening there? The pressure outputting from that catheter is causing what's called a nozzle reaction. It's actually pushing the catheter out of the way. So how hard are we flushing at baseline? So we have to be careful. Again, we'll figure that out during the workshop today. So how hard we're flushing, also the skin and how loose the skin is will determine your catheter extravasation. So if you have a 1.6 and there's only 0.6 in there because it was a deep vein, is that going to dislodge and come out? Probably, right? And so we have to be mindful. How about this? When you're doing ultrasound insertions and you compress that tissue, just because you want it, you're like, I need to get to it. There we go. You push it down. Now that vein is closer to your probe and you got it in really good, pushed it all the way through, got all the catheter in, and then you let go of that pressure. What's going to happen to that? Yeah. Little did I know. I mean, look, I prided on my first stick success in the ER. Now, how well they lasted was a whole different story. I had no idea. So we need to be mindful of them lasting a long time, or else it's going to mess with our schedule of having to replace these. This is what I'm trying to prevent, not just for the patient's sake, but also for our sake. How fun is it to replace that line that you placed that doesn't work anymore? It sucks, right? So I'm trying to give you guys some ideas on how to prevent that from happening, make these last longer for our patients, of course. Pulsatile for CVCs and laminar for PIVs. Here's why. Why do we do pulsatile? Does anybody know the answer to this? Yes?
Because we have evidence to show that there are improved outcomes by using pulsatile specific to removing the adherence of blood cells and bacteria.
Yes, it's a mechanical turbulence that causes shear force on the inside of the catheter, right? So it's causing that shear force in the catheter. What is it doing to what's right outside of the catheter? So if it's increasing shear force in the catheter, what's it doing to the vein right outside? Now for CVCs, there's so much blood flow and so much surface area that it may not really affect the central venous catheter. But for our PIVs, what is that turbulence doing to that vein right at the tip of the catheter?
Same thing.
Same thing, same shear force. And so for the longest time, I thought, push it, baby, push it. Let's get that clot out of here. Little did I know I was actually causing more damage. And I was wondering, I wasn't even wondering why they were failing. I was just, oh, that sucks. We'll just put a new one in, right? So something to consider. Here's also why we don't want to flush too hard with CVCs. Nozzle reaction. Has anybody had their catheters placed up in the neck? You're like, what the heck happened?
Yep, and then that's exactly what you do. You power
Almost there, but it hasn't
and
dropped
flip it
yet.
back down.
So we use nozzle reaction, high pressure. This is an intentional therapeutic high pressure performance. If you're not doing it therapeutically, just know you may be displacing that catheter where it's not supposed to be. And this is why how many of you have been told do not use a 3cc syringe when you're flushing? This is why, and I'm going to explain why they're wrong. All right? So why do we do laminar? Because it's less shear force on the veins, which I think are important for the peripherals. However, it does cost more volume. You need more flushes, more volume. And so if the patient is volume restricted, you don't want to do this technique liberally. All right, so here are the principles that help me to understand at a deeper level what the heck is going on. Bernoulli principle, Poiseuille's law, Venturi effect, hemodilution. All these principles were key for understanding at a deeper level how to prevent venous depletion with what we're doing. Which one is going to output more pressure, 3 or 10? Shout it out for me.
3.
Okay. Which one is going to output less pressure, 3 or 10? Shout it out for me.
You're wrong.
Depends.
It depends. Let's go into it. Because this is what we were told, right? And they're half correct. They're correct in this is what we normally do, but I'm going to teach you how to still use 3cc syringes and why the 3cc syringe is going to allow you to output less pressure and more pressure than a larger diameter syringe. This is a crude diagram to conceptualize the idea. With a Skinnier syringe, I have the ability to, it's easier to output less pressure and it's easier to output more pressure. I can achieve both granular and macro more easily with a 3cc syringe. What is that? It's human effort. Still don't know how to quantify it, but we do quantify it by PSI. That's the closest thing I can get is by quantifying the pressure to determine our effort. So, oh my gosh, I understand. I'm sorry to bring math into this, but it's very important. So let's take out the constants, things we can't change. The P is the pressure that we're outputting. Q is volumetric flow rate. R is the radius of the device that we use. The radius, diameter, okay? I want you to pay attention to this. When we look at a 3cc syringe, isn't it cute? The little brother of the 10cc, we use it for our pediatric patients, association, at least for me, I associate it with my pediatric kids. But it's not. It's a freaking powerhouse. It can output so much pressure, and it's because of this. It's an exponent, that's not a multiplier. What does that mean?
R times R times R times...
There you go, there we go. So it's a significant change in output, okay? So this is kind of how we need to look at these devices, all right? So volumetric flow rate is the key. I don't care what syringe size, catheter size you use, it's up to the person pushing it. How hard are we pushing it? The volumetric flow rate, that's gonna make a difference on whether we're gonna have poor outcome. Again, it's our effort. How easy is it? How hard am I trying? All right?
168. Did you catch that?
I was not, as you can tell, I was not expecting it to be that high.
Less than 1 psi.
I was testing this out,
What does it look like when I...
and I didn't know what the results were, and I just recorded my real reaction.
Did you see that?
So the hardest I could flush with the 10cc diameter, the hardest I efforted was 86. The hardest I efforted with the 3 milliliter Skinnier diameter was 168. What is this? Someone's changed tires before, right? Okay, so this is what I did. This is a car tire exploding at 170. Okay, 168. That's 170 right there. 168, that's me with the 3. And then I need some Ave Maria or something while it's playing in slow motion. Forgot to add that in there. Okay, now, it's not the same, as you know. We're not blowing up the veins with a 3cc syringe. We're not blowing up the I mean, you could actually. But generally, the surface area of the tire is significantly larger, therefore the force and the energy exerted is very different. But I wanted you guys to see the difference in pressure that we're able to exert. I just wanted that emotional pull of understanding. Oh, 168, even though I'm not blowing up a tire, probably not good for a patient, right? It's not the same thing, but let's be mindful is the point I want to get across, okay? So it's not a fair comparison, but it's like the best comparison I can get for you guys to understand that there's a real consequence to the amount of pressure that we're applying. So, friction from catheter pistoning and stasis of blood flow. What are we talking about here? All right. Catheter to vein ratio for non-vascular access. Have you guys heard of that? Ooh, okay. Anybody want to explain catheter to vein ratio?
Hi guys. Yeah, speak up.
Yes, go for it.
All right. You have to be taking up 45% or less of the area or volume if you're thinking of a tube, but I like to think of a circle, the area of the vein, so that you'd have like 55% of the area that blood can still flow around it.
Bingo, blood flowing around it is key. The more blood we can flow around that catheter, the less likely it's gonna clot off. Remember, hemostasis is one of the varicose triads. So when the blood flow slows down, we start clotting off that catheter in that area. So I want you guys to be mindful of this. How many of you have been told fibrin tail? How many of you blamed it on a fibrin tail when it doesn't draw blood? How many of you blamed it on a valve? The valve gets a lot of heat for everything that goes wrong, right? So this is an image of a real fibrin tail. Can you turn off the light for a second? I think I can see it better.
Is that a PIV?
That is a 22 gauge, 6th day dwell. There we go.
There's too many buttons.
No, you're good, you're good.
Okay. Oh, wow.
That's when I try to aspirate. I actually didn't expect it to crumple up like this.
Do you think it's coming out of the catheter?
No, I think it's from the outside, not the inside. Just from the shape of the lumen. If it was from the inside, it'd be a solid core.
And you have a valve right there too.
Yes, bingo, right there.
So go to the beginning of that, because it looked like it came out.
It did. There was a little bit at the tail end, and when I flushed it hard, that force pulled that sleeve out. So I like to call the fibrin foreskin. And then when I try to aspirate, you could see it crumpling up. Is this safe to use? Why not? Can you still give medication? Yeah. Is it going to hurt the patient if you run it through this little extra thing? No. You can't draw blood, but you can still use it. How many times have we said, oh, it can't draw blood, it's having a heart, we're just going to pull that out because we're not. How many policies are told if you can't draw blood, it's no good?
On a
Now-
PIV?
Uh-huh.
Not on a PIV.
There's some confusion there for some institutions. I've had people commenting on my post. They tell us if it doesn't draw blood, we got to put a new one in. Yeah. Now, with ultrasound, I was able to assess and let the nurse know, hey, you can keep using it, don't worry. Just forget about the blood, just do another venipuncture, but you can still draw blood. Now, is there anything we could have done to get rid of this?
3cc, possibly.
3cc flush, yes, possibly. I was so freaked out. Yeah. I was so freaked out because I'd never seen this before. I didn't know what it was. And I wish I'd tried to flush it off, but I was like, I don't know what this is. I want to pull it out to see what it looks like. And you know what I found out? It stays in the body. So it gets caught up in the tissue and you can't retrieve it. It's that soft, it's that...
Embolize? Do they ever embolize?
Question, I don't know.
Of course they do.
Yeah, we do.
They embolize, but are they going to cause a pulmonary embolism is really what we care about.
No, it just goes to the lung.
Bingo. Filtered out, right. So not overly worried about something like this floating around. Like you said, the lungs filter it out for the most part. It's usually, has anyone seen an actual PE clot? It's huge. You could chew on that thing. It's so big. So it's not a small piece. It's a pretty big piece. All right. So hypercoagulability, this is when we know and assessed our patient's chart that this patient's going to have a problem. Diabetes, dysautonomia, connective tissue disorders. It's up to us as specialists to plan more for the patient, have options for the patients as well. How many of you are vein mapping before insertions? Not for all of them. But for some where you're like, yeah, they look complicated.
Simple scans.
There's a leaf. So we got a valve right about there.
So with the ultrasound, you're able to see where the valves are. This particular patient.
Yeah, you see the two leaflets right there. Yeah, two leaflets, so the valves are very close to each other. And then another one over here, that's another valve. So if I want to end here, I need to insert at this point, and that'll be my insertion. That way, make sure the tip terminates. Yeah, and that one will get...
This is so extra. Just put it in. All they need is hydration. Good Lord. Don't worry, I get the same feeling when I watch this myself. And it's me. So Oh, yeah, this is just assessment. So for this particular patient, I wanted it to last 7 days because they were about 2 hours away and I didn't want to have to drive back. Mobile vascular access. So I was like, this thing better stay in. And so I did everything I could to make sure it lasted a long time. All right, so there's something to consider. When we blame it on the valves, do we really know? If you don't see it, is it really the valve? Or did we miss? So, catheter reflux, let's move on. Blood reflux is key to causing thrombosis on the inside of our catheters. Correct clamping sequence will help to mitigate this.
Probably seen this. Wow, look at that reflux. Jeez. We're going to simulate flushing techniques. I'm going to flush one more time just to be sure.
So these are all different models and brands of needleless connectors that I tested this with.
Most people do this. They take the hub off, they take the hub off, they take the hub off.
That's how much blood is refluxing into the catheter. That's the whole catheter being refluxed.
Now here's the next one. We're going to connect it. Do you see how much reflux into it when we connected it? There's no reflux when we connect. Flush that clean. Let's make sure. All right, clean. Now let's see what happens when we disconnect it.
So this is to demonstrate that not every needleless connector is the same. Some of them suck in a lot, some of them push in a lot or push out a lot, and some of them, anti-reflux is a key word, prevents that reflux from happening at all times. How many work in pediatrics? Okay, critical care, ED? PICU, okay, perfect. I didn't know this until I saw this for myself. I didn't believe it until someone said, hey, did you know? I was like, really? For adults, they probably could have used a bolus of a little bit of that pressor, right? Not a big deal if we bolus a little bit of vancomycin, whatever. Now, for our pediatrics.
Question, let's check out these positive displacement ones.
How much are we bolusing that pressor, milrinone, critical meds? And you're chasing after those blood pressures and you wonder why. So for pediatric and NICU, I don't really recommend positive pressure just because of this displacement issue. If there's a way that the manufacturer can prevent this from happening, I hope they have tips and tricks. I can't find it. So be mindful of what you're using. And remember, great for adults, maybe not for peds. So it's not that it's not a device at all, it's just who are you using it for? What is it doing? Ports. Yes.
Question on the positive displacement. What if you clamped it before the disconnection? Would you still get a positive?
What happens when you
unclamp that disconnection?
Would it, because the fluid's gone, would it still shoot forward?
I don't know. That's a good question.
So clamping sequence is key. Now, positive, neutral, positive, everything else in anti-reflux, there's different clamping sequences for those. So be mindful of the manufacturer's recommendations. First of all, you got to figure out which ones you guys are using, right? And what depends on the floor, you might be using something different. So there's a whole supply chain issue we won't go into. This is a really interesting study done by my colleague Connie. With port access, we are refluxing these all the time, and I had no idea. This is showing that when you disengage that needle from the septum of the port, and this is particularly portacaths, power ports and things like that, the apheresis ports work differently, their function is different, this doesn't apply to that. But when you lift up that needle, the septum deforms and reforms, and during that part, that reform and deformation, it refluxes blood into the tip of the catheter. Yeah, I had no idea. This blew my mind. So what are they recommending? Flush while you remove that port. So have it filled so that when it deforms and reforms, you have saline and it's not sucking in the blood at the tip of the catheter. Okay? It's not easy. Go try it. You need a third hand. So what I do is when I'm removing, when I'm removing, hold down the skin and like I flush, like I have the hub in between two fingers and then flush at the same time. Yeah.
What
Not ideal. I'm sure there's devices out there that mitigate this. Ooh, very good question. Heparin is debated whether it's useful or not. Yeah, you should do it. If you're going to use heparin, do it with heparin as well. Okay. Now this blew my mind. What does this mean for ports? Anybody know what this is saying?
Ensuring you have the bevel pointed a certain way.
Yes, that green arrow is where the flow of your flushing is going. And look at how much of an effect it makes depending on the direction of that bevel. What happens if we don't do this properly? I'm getting hungry. This looks delicious. Protein rich for bacteria. Nice, beautiful environment to grow in. So be mindful of where your needle catheter is and where your needle bevel is pointing. It's going to make a difference on whether you're going to fully evacuate or not. I did this because I thought if it's pointed towards the catheter, it should flush it better, right? I've been completely wrong. So this was an interesting study. And please don't, I know you might be tempted, please don't put in an IV catheter in your hubs. This is what's going to happen. Yeah, it's not a good look. Advanced aspiration, oh my gosh, we draw blood all the time. Who cares? Hi, this is lab. Your blood sample hemolyzed again. Not me. It was you. You lost it. You dropped it. It's all lab's fault. It's not us. Right? How many times did I not even pick up the phone for them to let me know it was hemolyzed? So cavitation and hemolysis is something that's happening, and I don't think we know it at scale. So I'm hoping that you guys will be equipped and take it to your institutions and teach it to the younger generations. Low pressure when you're aspirating. Pull pause if you need to. Let's talk about it. Hemolysis. Anybody know what hemolysis is? What is cavitation? Don't worry, I didn't know about this until about a year ago either. It's when the negative pressure or the change in pressure stretches that blood cell or even that liquid to create bubbles. Anybody know what the bends is? Diving sickness? Cavitation. They're all the same thing. So cavitation is the scientific mechanism of why the bends happens. Now, why the patient gets sick is a whole different issue. We're not going to go into that. Okay? So this is the many factors of why the blood is hemolyzing. Mechanical trauma, osmotic imbalances, chemical exposure, immune response, excessive pressure, lack of oxygen. Right here and here, that's pretty much us. I don't think lab has anything to do with those four, right? So let's talk about how we can prevent that. What is cavitation? Cavitation is excessive negative pressure. Do you know the negative pressure of your vacutainer tubes? Do you think it was designed to prevent hemolysis? No, it's designed to fill that tube to a certain volume. That's it. That's it. Now, cavitation stages is the nucleation, formation of the bubble, then expansion, then contraction. In that expansion, contraction, the rapidity, how fast it contracts and expands will increase that hemolysis rate. So when we're going gentle and slow with that syringe, less expansion and collapse. When we're doing what I did, give me that blood, and you're pulling on it really hard. How many of you seen bubbles come out of that syringe? This is what's happening. Now, is that sample going to be viable for lab? No. Most likely, yeah, you got it, and you sat there for 5 minutes. Like, you did a great job waiting, right? You did good, strong work, but that blood is hemolyzed now. So be mindful of how we draw that blood, how we aspirate. This is the data behind the aspiration and the dwell time of aspiration with hemolysis blood. Why is this important? Because how much money are we wasting on labs? How many of you told you're not allowed to draw from a PIV? Why is that?
Because you can destroy the PIV.
The PIV goes bad.
Same thing.
The cost of how much does it cost to run a hemolyzed sample?
$68.
How many times is that going to happen throughout your shift?
5.
a lot from your PIVs. When we're hemolyzing these samples, it costs so much money. Do you think if it didn't cost them money, they would care if you did it or not? No. If that reinsertion didn't cost them anything, they don't care. Poke the patient again. It's not our problem. But because it's costing them so much, they're like, hey, we've seen a correlation between us pulling from PIVs and hemolysis rates and replacements of IVs. Let's just stop. We're not allowing it. And it's because they don't understand the cavitation issue. So the cavitation issue is how I'm able to draw blood from a 22 gauge catheter, PIV, for, I think, 4 or 5 days while they're getting Lasix BID. Okay, so.
What kind of negative pressure it applies?
Your lav is -4 PSI.
So we got to about -4. Now let's see what happens when we pull it with a 3cc syringe.
And again, we're going to be able to do this at the hands-on workshop.
Now let's try with a 10cc syringe.
You can tell I'm a little autistic about this stuff, right? It's fun for me. I love it.
PSIs for just pulling on this syringe. So how hard you pull is going to make a difference.
So huge difference. Now remember the effort. It's not about the syringe size. I mean, it is, but the critical factor is how hard are we doing it. Okay, so be mindful of that. So I'm going to skip this. It's going to take a little bit longer. Just know, here's the evidence of the POP technique. This is a new study published in 2020. This is controversial, so I'm going to kind of breeze through it. You guys can read the study for yourselves. I found it very useful for my very, very difficult patients. Also, did you know that TPA can last how long? 24 hours, yeah. So if it doesn't work in 2 hours, keep it in there, let it brew, okay? So I had a patient who was really struggling to keep her catheter, and she was gonna have a very difficult time getting it replaced. So we ended up keeping it in there for 8 hours, and then it was fully patent. Okay, so where did I get that study? From the pharmacies who make this medication. All right, thanks for staying with me. Here is my contact. If this QR code does not work, feel free to email me. I'm happy to send you guys the link. Thank you for your attention.